Thank you so much everyone for joining us today for our panel on prescription for prevention, rethinking primary care. I will first of all say you were expecting another panellist with us, which was Jonathan Ashworth, who sadly is ill today and so sent his very profuse apologies for not being able to join us, but he's lost his voice, so he really wouldn't have been able to come other than sat here. But actually, dare I say, we have the real experts anyway at the table, so I'm sure we will still have a fabulous, gosh, this isn't even Chatham House, so maybe don't quote me on that, but we do have the real experts at the table, the people who actually do the stuff, who work day in, day out with patients, with the workforces that hopefully we'll get talking about in this session. I'm not going to say very much at all because, as I say, we have the experts, but we also have a lot of experts in the room, so I'm very keen that we get into Q&A and have that broader conversation. Other than to say that everybody will be very familiar with the last several decades' ambition, which is now one of the shifts in West Streeting's list of 3 shifts, which is to move care from hospitals into the community, and also obviously the shift from sickness to prevention. And primary and community care are absolutely at the heart of that, and yet despite the fact that around 90% of NHS activity happens in primary and community care, you can flip the budget on its head because only around 10% of the money in the NHS goes towards these parts of the NHS, and that's before obviously we even think about social care and the interactions with social care, primary and community care. So clearly something has to change. We are sort of imminently going to be getting the 10-year plan. I don't know quite how imminent that's sort of stretched out, but hopefully spring, summer, early summertime. And it's going to have to outline how those shifts are going to be achieved, and therefore how something quite radically different is going to happen if that's going to be achieved. I'm thrilled to be joined by, as I say, such expertise. They need no introduction, so I'm literally going to tell you who they are rather than their, kind of wonderful biographies, which I'm sure you already know or you can look up. But I have Professor Dame Clare Gerada, who is co-chair of the NHS Assembly, but also formerly the president of the Royal College of GPs, and still a GP? Yeah, still an active GP, wonderful. We have Professor Nicola Ranger, who's General Secretary and Chief Exec of the Royal College of Nursing, and it feels like often nursing is left out of the conversation despite being absolutely fundamental to primary and community care. So we're thrilled that you are with us today. And then we have Reform's very own Rosie Beacon, who is our head of the Reimagining Health programme here at Reform, which is a huge work stream that we have here, and also the lead author of our series called Prescription for Prevention, which is Rethinking Primary Care. So if you haven't looked at that series of 3 papers, please do. I'm going to start by asking each of our panellists just to do some brief opening remarks, because I do think the richness of the discussion comes from the questions that we ask and delve into different particular areas that each of our panellists will want to highlight. So we'll go through those, but please do be thinking about what your questions are. As I said, we do have, looking through the, someone said genuinely upstairs in the office earlier, looking at the guest list, or the attendee list today, gosh, it's like looking at like a party you're holding, and like you've got all these names coming, and it's really exciting. So it's brilliant to have you in the room. Please think about the questions or points you want to make when we come on to it. Otherwise, Claire, can I start with you?
Yeah, thank you very much. I'm going to be a few minutes. Who here is Bob Dylan fan? Quite apologies then. I'm just going to read a few lines. So, how many patients must a GP see before you call him indispensable? The answer, my friend, is blowing in the wind. The answer is blowing in the wind. Apologies. And it is blowing in the wind. And I have in front of me, and I asked for an overhead projector, but they went out with the arc. And those of you who are very young, they're things that you put acetates on, of which I have an acetate. But I've got actually something from 1963, the field work of the GP. It cost in today's money 20p. And it talked about, and this is round prevention, it talked about engaging technology, it actually uses that word, and it actually talks about continuity of care, of bringing the biggest bucks for your money. With slight inflation, 65p, which is the organisation of group practice, and again, it talks about working together across primary, community, and it even talks about secondary care. The language it uses is different. The talk I gave 25 years ago, or actually talked about the future of general practice and talking about we're dismantling what works, which is the jewel in the crown of the NHS and general practice, unless we get reform. And I talk about joint working. And then I've got all these, and I promise you, this is just half of what I've got. And they all say the same thing, which is the bit that works in the NHS is primary care. Is the GP providing continuity around access? The bit that doesn't work is what we've got. Nothing against my hospital colleagues, is the bit that works across the divide, is the joint working. We're working today as we did in medieval times. We're working today as we did in the when the NHS was first set up, and I'm sure we're going to see how things have changed. We know how things have changed. So the answer is blowing in the wind. It isn't about, yet again, changing. It is about implementing some of the, and I've counted them up for your pleasure, 12,000 recommendations made in the various reports that I've been privy to. And I noticed the name on the brilliant report in Reform has all of my old friends there who was probably signatory to this. So what is the answer, ladies and gentlemen? The answer is about breaking down these barriers between primary and community care. The answer is investing in digital technology. It is, we can do population health management at scale, and I mean at scale, 1, 2, 3, 5 million population now, relatively easy. It is about providing digital triage and what I call an air traffic control system. Around 30% of all patients today are in the wrong place and getting the wrong treatment, with the over-medicalisation and the pain and anxiety that this causes. So it is about developing and embracing digitalisation, not being frightened of it, as we were during the pandemic and had all those silly stories about the error rate, which I worked out was about 1 in 3 million error rate, compared probably about looking at my surgery this morning, 1 in 30. Please don't quote me on that. So the answer is blowing in the wind. If we don't change the other end of the system, we're going to get what we've always got, and it is not just about tinkering with the edges. It is about moving your hospital colleagues out of hospital. It's about changing the way we do risk and gain sharing. It is about changing the way we use premises, and it is about changing the way we fund services. So that's my starter for 10. And apologies for dinner, but I did go and see the film last week.
Brilliant, thank you so much. I love that we have props as well for this panel. It might be the first time we've had props at a panel. Rosie, over to you.
Yeah, so I mean, as Claire compellingly emphasised, the prevention argument has been made for many decades now, and indeed, as we emphasise in our primary care papers, which I'm sure all of you haven't been able to put down since they were published, that to survive the challenges of the modern age, it is an inevitable fact that there is a broad consensus the health system must transform from a sickness service to a health-creating service, and I think there's little dispute that that's something that needs to happen. And as everyone's aware, this is not novel. But actualisation of this has proved consistently difficult and unsuccessful. And as Charlie alluded to, 90% of daily activity in the NHS happens in general practice in the community. And if the primary care model is no longer fit for purpose, then it weakens the foundations of the entire system, which we're seeing at the moment. But the kind of model that our paper promoted was about taking primary care outside of the four walls of the GP surgery. We believe that general practice obviously plays an instrumental and foundational role in the future of primary care, but so do many other things that often don't get a word in edgeways in the debate on primary care. And what's more, the system is designed, as it is designed, is mostly reactive to clinical need rather than being proactive, and we really wanted to flesh out what this looked like in reality. What kind of roles do you need to introduce into the primary care system? How does the workforce need to adapt? What kind of technology needs to be introduced? And as part of this, we identified 3 core pillars. The first is to intervene early, which sounds obvious, but actually the primary care system is not set up to intervene early and requires explicit interventions in order to do this. To respond faster. When somebody does have a clinical need, the general practice and primary care need to be able to respond as quickly as possible, and to help avoid decline. As I'm sure everyone is aware, the demographic demand on the health system largely consists of people with long-term conditions, and often multiple long-term conditions. Decline can happen very quickly if it's not managed properly, and this again falls into the remit of primary care, but is often underestimated in the face of acute crises. So we recommended a range of different interventions, actually over 20 if you're interested, but I'm not going to talk about them all today, but I will highlight some of my favourites. One that I was actually discussing with Nicola before the panel was the role of community health workers. Now this is a model that's been rolled out in Brazil, and it's actually been rolled out in a few communities in the UK, and is chronically underused. It's extremely simple, extremely cost efficient, and it literally just involves people knocking on someone's door in a hyperlocal community, so usually responsible for about 200 households. It's extremely proactive, it's extremely personalised, and it's extremely effective at surfacing clinical problems that we may not have otherwise surfaced had we not reached out to them. Again, it's exactly the preventative, proactive healthcare that everybody's been desiring for so long. It's a super simple intervention and yet consistently underestimated. Another thing that Nicola and I were discussing is the role of nurses. The nursing workforce is such an untapped opportunity for the government that they consistently underestimate. The number of nurses in the primary care workforce, I believe, is 23,000 versus 405,000 in secondary care. If ever there was an example of having to make difficult decisions about where you allocate your resource in the health system, the nursing workforce is the perfect example of that. The disproportionality between primary and secondary care when it comes to the nursing workforce should force policymakers to reflect and think about how you prioritise your resource. The way that you could use nurses in secondary care in the primary care environment is, potentially unlimited and could tap into an enormous amount of demand on the primary care system. The complex demand, the less complex demand, it generally helps to deal with volume across the system. But like I say, it's not just about increasing capacity in general practice, it's also about helping to prevent, but also to help avoid decline. Helping people to manage their conditions, whether through health and wellbeing coaches, more effective remote monitoring, or again, through the roles of district nurses, is absolutely essential for the changing demographic demand on the health system. But ultimately realising the long-held ambition to shift demand into primary care and secondary care and to design a more preventative healthcare system will be impossible without considering actually a lot of these fairly straightforward interventions that, like I say, are consistently underestimated by policymakers. They wouldn't be that expensive. Some of them would require making difficult trade-offs about where you allocate your resource, but some of them wouldn't, and you could roll them out tomorrow. They're ready-made innovations ready to go. So, like I say, as health becomes more and more multifaceted, I think the primary care system should too.
Thank you so much. And Nicola.
Thank you. Good to be here. I think just following what was said around digital, I do think as an NHS we still somehow struggle to get this right. And when you look at what other countries are doing, they are doing things at a scale we couldn't even begin to imagine. I saw a recent talk around what India is doing. They're not just doing things in the thousands, they're doing preventative agenda in the millions. Whereas their primary health issues were typhoid and other diseases, it's now secondary, like hypertension, diabetes. So they are doing so much in that preventative agenda, with nurses going out with really good tech to do blood tests, to do screening by the millions. Actually, it is quite astounding what others are doing, but they're upfronting and recognising it's expensive, but it's worth it. Look at places like Japan, where they've got the oldest oldest population in the world. What they are doing on older people's risk by capturing their data is way ahead of ours with regard to digital technology. So we talk about digital, we can't even talk from social care to a hospital at the moment. And I think we keep hearing the government say, digital and IT is the answer. Well, actually, it needs investment, because, and that's our frustration. It's all talk. This is billions of pounds, which is what India and Japan are doing, but they're reaping the consequences and the benefit of, this is investment that may take 5 years, 10 years to see. But I think at the moment, I hear the words, but I don't see the ambition about reality. So I think we've got to change that. With regard to community, you're absolutely right, Claire, around, we've been talking about this for a very, very long time. But in reality, it is still far too focused in the acute sector. And we talk about the community, you said about nurses. I met a group of district nurses recently who we talk about the visits. This was in London, so you think they could get from A to B relatively quickly compared to rural areas. They were seeing about 28 patients a day on 15-minute intervals. That was the reality. How could you possibly fully assess someone's needs to both prevent them going into hospital or look after them when they've come out on a 15-minute interval? So if we are going to invest in community, then let's properly front load the community nurses actually, and that's either from a GP practice or actually district nurses. And GP practices, we've got to change the contract, because it's very difficult for GPs to have the finances to properly support nursing roles. An advanced nurse practitioner, a good GP nurse, is absolutely vital with regard to clinics and really freeing up the GP's time. But actually at the moment they're not on the same terms and conditions as the NHS hospitals. So if you are a GP practice and you've got someone going on maternity leave and you're paying, just state a benefit for maternity leave, but an acute hospital is giving them full pay for 6 months, when you're a 90% female profession, where are people going to work? So until we support GPs to at least match Agenda for Change terms and conditions, we are not going to make the shift from hospitals to GPs. So properly give GPs the tools and the finances to entice nurses into their practices, and then invest in roles like advanced practice. With regard to the prevention agenda, I've got to be honest, we did talk about the community support workers that are in the paper. I struggle with that, because I think when the absolute complexity, which is in this report, is comorbidities that's going to go up, I'd rather see the investment in a skilled professional than a support worker that cannot have the clinical expertise. You want one conversation once and wisely, rather than multiple handoffs, which is ultimately what you have when you have an unregistered workforce. So I think there's something in that prevention agenda that properly needs investment in skilled registered professionals. And it's interesting to note that since 2009, the number of health visitors and school nurses has gone down by 45%. They are essential health visitors and school nurses. So a 45% reduction when schools are a vital place to look after the population as they come through, and health visitors, 45% reduction. So I think we fully applaud the government's 3 key ambitions, but they're just going to be ambitions on a paper, unless there is proper acceptance that these things need investment and front loading. And actually, if we want to make those shifts on all 3 of those things, I'm really tired of hearing no money, no money, no money, because there's going to come a point where we're paying a far greater cost with patients in inappropriate settings, corridor care, which we made a big fuss about all over the place. If we don't think that's costing money, both in mortality, morbidity, and pounds, shillings and pence, then we're really deluding ourselves. And I think this government will fail on all levels unless it recognises that we need to front load that shift from hospital to community. And I would say this, but it's absolutely vital that GPs are invested in, but it's also absolutely vital that nurses and registered nurses are invested in. And when 40% of GPs are reliant on international recruitment, and it's 50% of nursing, we've got a serious problem when we have not got a domestic workforce. We talk about we've got a responsibility in primary care and community on universal health coverage, which was the envy of the world when the NHS has come in. Other countries are trying to achieve that, and we are depleting them of their workforce, which actually I think also needs close attention for us to get that proper shift to a new role model of primary care.
Thank you so much. Huge amounts in there. I'm going to start with Chair's prerogative and ask a couple of questions first, as you will think about what you would like to hone in on of everything there, from the funding model to the workforce to the tech to the digital to the data presumably underpinning. I mean, we could pick any bit, including maybe a discussion around some of the international examples and why we're not great at learning from those. I want to start with this question of funding, because all 3 of you have mentioned this, and the government did manage to find almost £23 billion over 2 years to put into the NHS. And yet nearly all of that is going to go into the hospitals, which is the thing we're I think, saying we don't want to be investing. I think the shift is hospitals to community. So we all understand the wait list, we all understand the pressure that is, we also understand in the public mind, this is politics after all, making decisions. But when we have government after government saying one thing and literally doing the opposite, when we talked about workforce numbers, if you look at what's happened to numbers of doctors in hospitals and you look at number of GPs over the last decade or so, you point out health visitors, community nurses have gone down, doctors in hospitals massively up. How do we shift this? What is the mechanism? Are ICSs a route to that? Do we need to be thinking, pooling? And I'm glad to see people shaking their heads. We've been very sceptical at reform on ICSs. But that was supposed to be a way of integrating funds and money. What is the model that shifts this? Claire?
It's like, because we've been there before. Number one, you've got lots of experts in the room. We've been there before. I've got an acetate here of all the acronyms of all the various ones. I put 2 in there, which was pigs and pods, to see if anybody could actually spot the one that nobody did when I showed it 20 years ago, whenever we had pigs and pods. I mean, I think we have to start. I've thought about this so often. I mean, we have these 3 shifts. It's really good, but actually it's not going to get us anywhere. Because what I think we have to do is to decide what is the offering that we want to give to patients. Okay, what do you ask? When patients say what do they want? They want 3 things. They want access, they want continuity care, and they want, we call it prevention. They want to stay fit and healthy. There is a 4th, they want to die with dignity in the place of their choice. But we then have to set standards around that. Now we've got standards for primary care, we've got standards around access, we've got standards around continuity, and we've got standards around prevention. I disagree with your point about prevention. We have 1,000 QOF indicators that we have to meet every year. So we are proactively, that's why we've seen massive improvements in healthcare. But there are no standards, equivalent standards for hospitals. For hospitals, there's no equivalent standard. Where's your access? Well, you have some access standards, but where's continuity of care standards? Where are prevention standards? Where's population health management? So if we start with that, and then say, right, what are the enablers and the enablers and the barriers to creating that? Then you can start to unpick it. The barriers, the fact that we have different funding streams, the fact that we don't have even an RO issue about getting hospital doctors employed in primary community care. We have barriers around premises. Why can I not, as a GP in my area of 35 years, not have an honorary contract with my local hospital so I can have meetings in my local hospital, so I can see patients in my local hospital, which we used to be able to do in this report, 1963. So we have to stop looking at models of care. I'm going to swear here. We really have to stop it. And we have to start saying, what is it we're trying to deliver? And then I'm afraid the biggest, and I know I'm on camera, the biggest barrier to change is my profession. I'd also say in particular, though I'm biased, and please forgive me, hospital doctors, the hospitalists, the secondary care, because we're asking them to move out into the community to work alongside me, to be I'm not their handmaiden, I'm as skilled as they are, if not more skilled, but to work alongside me. We're asking them to look at equal terms and conditions of pay, so that how you can have 13 PAs when there's only 10 in a week, and exactly around nursing staff. So, but they won't be the barrier. The biggest barrier, we are asking, why does it take 5 hospital doctors for 1 patient per hour when it's 20 patients per hour in general practice? These are the things. Why can't we use digital triage so that I saw a patient today who needs, he's got a hammer-toe, simple procedure. It takes me longer to write the letter to the doctor than it took me to see the patient. Why is that? Why can I not just click a button or ask the patient to directly refer the patient? So the problem is, all you clever people constantly do
I feel like that's an insult, even though I know it was supposed to be.
How do we reform primary care? Stop it. Stop it now. How do we put what we need, that patients need and want? And I disagree with the coaches. What we need is to empower them, as I do with my app here. My gym man has exactly the same, he knows how much I'm walking. Why don't we empower the patient to make their own health? Why do we need to go and knock on the door? We're not in rural Brazil. We're in really, I know we're in a recession, etc. So that's it, we need to turn the whole thing upside down. Then the funding changes. Then we stop giving more money, £5 billion 2 years ago for unnecessary investigations in A&E. We've got Simon here, and I think you gave me that paper. £5 billion for unnecessary investigations, which clog up our awards by the time you've sorted that. So stop reforming primary care. My plea is to stop this and to start at the other end. What is it we're trying to achieve? What are the barriers and facilitators, and how do we then get the profession on side to change?
So much there to unpack. Thank you, as ever. This is why we love inviting you, Claire, because you're provocative and you say the things that actually you mean, which is always a delight on the panel. I would gently say I don't think we've still solved the problem of the funding and the fact that at the moment the model is still, you know, the money goes to the hospitals and they've got an entirely different incentive structure than GPs have, and actually if we have, you know, a current model where all the money goes in there, then that is very hard to do all of the great things that you've just discussed, which I think is why us clever people come in to try and work out how you solve these problems.
You don't reform the hospitals. I've never seen a reform paper. You talk about commissioning, you talk about reforming primary care, all of the King's
Our current programme is the Hospital of the Future.
But so not the community, not this.
And then we're taking each pillar and we will go through it.
Pillars.
So, well, the problem is they are at the moment, but we're gonna pause there. We're gonna pause there so that I can bring in the other two panellists, because they very much are distinct things at the moment. So, Rosie, I'm going to come to you because we have talked about the funding model and why this is such a barrier to being able to do the shift. Do you want to summarise the reform position on that?
Yeah, just very quickly though, it's also the reform position that if you can't shift to a model of prevention without thinking about the role of the hospital within a preventative model. We think this is actually a huge flaw in shifting to prevention, in that nobody really knows, like hospitals are having an identity crisis, nobody really knows what they exist for in a model of prevention.
Sell you Marks and Spencer's food.
Pardon?
That's true.
I
think that's probably one of the improvements.
Yeah, I don't actually mind the Marks and Spencer's food, but anyway. With the funding model though, as we've outlined in multiple reform papers successively, is that the funding incentives don't exist in order to shift resources into primary care, which is why, and I'm sorry if any of you work at NHS England, we suggested abolishing NHS England and shifting all healthcare responsibilities to combined authorities or to the regions, because we felt like actually the evidence suggested that this was the best way to kind of create the accountable care organisation model that actually inspired ICSs, but we've actually not been able to achieve. The whole premise of ACOs in the US was that you create the financial incentives to shift into primary care because you benefit from the cashable savings that you would make by investing in primary care. Again, that was the premise behind ICSs, but because of all the central targets from NHS England, it's been impossible to realise this. So it's consistent throughout a lot of reform reports on healthcare that actually the route to shifting towards a model of prevention is by creating the right financial incentives in the system, which creates certain types of behaviour, and that behaviour should theoretically be preventative. And there are lots of case studies across the world where, when the ACO model has been properly adopted, it's been successful in kind of shifting a lot of care upstream. Obviously, not all health systems, international health systems, are comparable because they all have different operating models. There is a lot to learn from how you design funding models within a system and the kind of activity and behaviours that they reward. So that's why I would say the reform position is on the funding model.
Great, thank you. And Nicola, I do want to address this. Why is, given anyone who understands how the health system works, understands just how crucial the nursing workforce is in it, and yet, as Rosie said, we very rarely talk about the nursing workforce compared to doctors. As you've said, the money isn't being invested in the nursing workforce, despite the fact that they are there in the community and with a increasingly frail, multi-morbid, ageing population, and actually community isn't meaning going to a GP surgery, right? It's meaning that nursing workforce and others that you have actually there helping people in their homes, in place. What would it take to break through and actually say this is the place to invest?
I genuinely, I want to also pick up on some of the other things on the comments, but I do not think that the UK is really acknowledging the massive nursing crisis in this country. Cardiff last week is planning to consult on stopping its nursing school. As I said, 50% of the NMC register was from nurses from India, the Philippines and Nigeria. That is morally not right. It is no longer becoming a profession that people want to go in, that they want to stay in. And actually, I think this has got to be sorted out. Whether we like it or not, the 2016 issue, particularly in England, of saying that nurses need to become a regular student has been an unmitigated disaster. They have to do 2,300 hours of clinical placement. So they're not like, I know my son's at university, I know how many long holidays he has, and he can get a second job. Nurses cannot. In their holiday time, they are working clinically. They are financially, completely and utterly not doing the job because they can't afford to. That has been a disaster. The numbers have gone down. It was meant to open a free market and it hasn't. The number of going into nursing has gone down by 27%. So we have got a massive crisis, and nurses are at the bottom of the pay agenda. Now, I don't want to take us off track, but if we've got a small amount of money, we rightly have invested in medical staff, the junior doctors. Their strike action was hard fought and right that was sorted. But when you've got this government now putting money into a minimum wage, which is also fine, but what that means is between a nursing support worker, band 3, and a registered nurse, there's now only £6,000. That differential with minimum wage is going to get even smaller. So we are weighted to the bottom. We are 62% of band 5s are nurses, and we are the only profession that will start a career as a band 5 and retire. So pay has got to get sorted. So I just do not think this government we are having nice words, but we need action. And until we support the supply, it will be very difficult to get that shift from hospital to community. I also just want to talk about, you talked about America is often used as an example of efficiency.
Sorry, I do want to clarify, we have never argued as America's efficiency. In fact, it's a very costly system. The point is the accountable care organisation of integrating the different parts. Just to clarify, we are not arguing for the American system.
But there is some learning from there, and I was one of those nurses when America had the US shortage. They came to expensive hotels in London, and people like me were enticed. We had intensive care skills. I got to go to New York, Mount Sinai Hospital, a green card, an apartment on Madison Avenue, blimmin' marvellous. So absolutely fantastic. But America used that opportunity to say, we're far too reliant on international nurses. We are going to sort it out. We are so reliant on internationals, but we're not doing what America did and say, what are the levers that we need to change to sort it out? Now is our moment to sort that out. And I have to say for hospitals, you're really right, Claire, in your observations, but I do think, and I'm not defending hospitals, but sometimes they are looking after patients that they know would be better cared for elsewhere. When a third of hospital wards are full of people that actually an acute hospital is not where they need to be. We've got to properly sort out social care, and that is a real another subject. But we do have to find a way to get some of that better. And at the moment, I think it is incredibly inefficient. And I think people are languishing in wards that really should not be. But until a community response, I was in Northern Ireland, and there were district nurses there that were offering 24-hour service 7 days a week. Until we want to shift that community, I'm afraid, particularly for nursing staff, it can't be Monday to Friday. It's got to be 7 days a week, 24 hours a day. So let's properly invest in it, because that's the only way. Otherwise, the hospital will continue to be the default. Because if you've got a service at 8 o'clock at night, patients in difficulty, and the only choice is to call an ambulance, we're never going to get that better. Community has to be 24 hours a day, 7 days a week.
And you can't discharge people from hospital because actually social care is in such a state, and etc, right? So yeah, absolutely. Okay, I'm going to open it up to questions, as I fear we'll get in another massive conversation about a particular area, and so many hands going up. If I can ask you just to say who you are, what organisation, so that the panellists have got some context for your question, and if I can ask you to keep it to a question, because I can already see quite a few hands have gone up. I will interrupt you if it's not, just to make sure that we're respectful of everyone else in the room, to make sure we get around people. So I think hand at the back shot up, and then the gentleman here and the lady at the front, please.
Thanks. If we, sorry, Simon Eccles, now working at Salesforce, once upon a time NHS England, and they deserve the kicking they should get. Now, if there's no new money, because I agree with investing in primary care, we woefully underinvest in primary care, money's going to come out of somewhere.
Exactly.
We need to do the same or more with less cash. Every other industry is looking at that. That's the profit motive that drives the world, and most have done it through digitising all of their processes. And they've done that through ruthlessly streamlining. If at 92 you come into Guy's and St Thomas's emergency department, as an absolute minimum, you will see 4 nurses and 5 doctors before you make it to the ward. I can't help feeling that you probably knew what was needed before you arrived, and we don't trust patients with their own data.
Sorry, Simon, the question?
So the question is, please, can somebody break the mentality in NHS England that digital is a sideline and weird and special and doesn't really need investment, and turn it into the core of how we're going to enable everything you've just
Great, I'm going to take 3 questions at once, and then I'm going to come back to the panel. So, short answer, but we're going to come back for a more detailed answer on that.
So, Adrian Hayter, Medical Director for Clinical Policy at our College of General Practitioners, and previously NHS England, National Clinical Director for Older People. I wanted to give the hospital at home policy, or the virtual ward policy, just a bit of consideration, because it's an example of, and it was a policy that I was involved in as National Clinical Director in terms of creating the policy and getting the funding, which was £450 million of funding. And I thought, that's fantastic. Older people are going to be supported at home within their own homes and get the care that they need. But what happened was a lack of transparency, an obfuscation of the funding around that £450 million. Ask now how much of that money has actually gone into community nursing, has gone into general practice, has gone into the community. Most of it has got filtered away into acute hospital care.
What a shock.
What a shock. Until we get some honesty
Yeah.
and transparency, we'll never get to the place that we want to be. And the second bit, if I might, just in terms of nursing, well, it's the nursing bit and the community health workers. Yeah. We've got actually people in the community who can do those kind of roles. We need to think about them. The postal worker, for example, in other countries support some of that. The Royal Mail actually have an initiative to try and get that off the ground. There are, 100,000 postal workers. So let's use the resources within the community rather than just go and invent another workforce.
Brilliant, thank you. And Rosie will be delighted on the virtual wards, as her and Alice were in a virtual ward on Friday doing a visit in Cambridge. Brilliant, and the lady who just hit.
Yeah, thank you. So Rebecca Gale, I'm Assistant Director of the Primary Care Network at NHS Confederation, membership organisation for the NHS, but our network represents at scale primary care, not just at scale general practice, but community pharmacy, optometry, dentistry and audiology. So just on the side, it'd be interesting to get reflections on kind of how the wider primary care fits into this picture as well. But my question was, Claire, I was really pleased to hear you talk about patient empowerment, because this is about a different conversation and about relationships and trying to talk about the other enablers, digital data, obviously significant ones, but actually if we're talking about new ways of working, that requires a high level of trust between professions. So how do we move to a high trust model? What's the role of perhaps the Royal College of Systems? Because you are asking professionals to work in a very different way and to make workforce for the future. But yeah, it's just really interesting in wider primary care perspective.
Brilliant, thank you. So 3 wonderful questions there. Why don't we take digitisation seriously, and isn't that the route to lots of efficiencies? And I guess the kind of what's the equivalent of making a profit in the health system? It's actually sort of gaining capacity, right? Because we're not going to be making savings, we're going to be able to support more people if we can do it in a more efficient way, and that's, I think, the less point. So question on the digitisation stuff, question on I think more broadly the virtual ward is a great example there in the money you gave, but actually this is what we've been seeing for an awful long time, right? Money that's been earmarked for something getting snuck back into just day-to-day acute services, right? Which is part of the answer of why digitisation hasn't happened. Sorry, I'm not answering the questions. Possibly. Sorry. And then also linked to that, the kind of using community assets in this sense, and which links to how do we think about primary care as a much broader thing than perhaps we've been discussing. and obviously that idea of the high trust, and one of the stats I'm always most shocked by is when you look at the workforce data in the NHS, and it's something like 1 in 4 or 1 in 5 have experienced bullying, harassment or abuse by colleagues. So there's a whole set of questions about trust across different parts of the system, but there's also a lot of questions about the working environment in whether it's a trust or hospital or whatever it might be. So I do want to get to another round of questions. I'm going to ask you to either pick 1 or 2 or very briefly answer all 3.
Well, I'll very briefly answer 2. The one
Okay.
about, I think what you're talking about is professionalism, who holds the ring when you have multidisciplinary or you have people wandering, moving around the system. I've actually looked into this because I run 2 big services. It's not a big issue. It's more in people's head, your head and my head, than it is in the team's head, because if you've got professionals, then they are bound by the professional code, and actually what you find is you have MDTs, you have a joint electronic record, so it's not a big deal. I will answer the digitalisation one. I think we invest 1% of the NHS funding into digital. I think your equivalent companies would do 4 or 5%. And it's always raided, and we put in 300 different procurements. You can't procure. It's crap, okay? And until NHS England sort it out and actually start to invest in full digitalisation and stop this idea. During the pandemic, it was, oh, but what about people who are digitally illiterate? Well, we never asked that when people couldn't read or write. When I started as a GP, there were many people who couldn't read or write. We've just got to assume that everybody can use this, and the small percentage of people that can't, we can help and support. Air traffic control, we've got to link the doors, which is why I really get fed up about hospitals and this. We've got to say there is no wrong front door. Use an air traffic control system embedded with good digital template, and you've sorted it out.
Great, thank you. Nicola, did you want to pick?
Yeah, I mean, I'm not going to repeat because of time because I talked about digital at the beginning, but I think there's something really important. We talked about, not everything can cost money, what else are we going to do? I really do think, actually, and I can't talk with authority about GPs, but I certainly can about hospitals. Clinicians now, I believe, are not working at the top of their licence because, and it comes back when I saw you holding up the pamphlets there, in years gone by, people could make a wise decision. They made a clinical decision that sometimes they may get wrong, but 9 times out of 10 they make a wise decision. The current environment that we are in now, where there's so much scrutiny, if we think there isn't a blame culture, we are so wrong. The CQC have criminally prosecuted more healthcare professionals than ever in their history in the past few years. The coroner, we know, can be really difficult with regard to the personal responsibility of professionals. It is far easier to admit a patient than to make a wise decision to not treat someone and send them home. So many clinicians are far too scared to make a wise clinical decision because we work in an incredibly hostile environment. And until that changes, and that is for professional colleges to change with their support, NHS England, or all of those people, because if I'm honest, it is really difficult to make a professional mistake in our current environment. Everybody wants blood, and I talk about partnership, but actually I think some of our families can be disproportionately hostile to a clinician that can sometimes get things wrong. 9 times out of 10 they'll make the right decision. The one time they don't, it is a very hostile environment, and it makes people risk averse. To make truly patient-centred decisions takes far more courage than it does to just do the easy option.
Great, thank you. And Rosie?
Yeah, so to Simon's question about digital, what was really interesting in the primary care paper was actually we found that a lot of the obstacles for rolling out digital were quite straightforward. So a lot of GPs don't roll out digital because they're not experts in change management, and a lot of it involves rethinking process and clinical workflows. They don't have the time to do it, so they just don't do it. There was also some other stuff that came up a lot about the analytical skills in ICSs. So we talk about rolling out population health analytics, but actually we don't have analysts sitting at the ICS level that are able to do it, so how can we do that? That is actually fairly surmountable if you think slightly intelligently about the incentives to work in an ICS if you are a skilled data analyst. And then there's also some things around interoperability. I'm sure everybody's aware of this, that some hospitals have digital systems that don't talk to other ones which don't talk to GPs. That is also surmountable, whether it's with kind of competition legislation or actually just forcing the companies, as they've done in America, they've done before here, in terms of forcing them to be interoperable with other systems. As Charlie alluded to with Hospital at Home, we are huge advocates of the virtual ward model. We were at a virtual ward in Cambridge on Friday, and a room maybe like a third of the size of this, with about 6 people, was managing 50 patients from one room. It's astonishingly cost efficient and astonishingly underused, and how the funding's allocated is a huge
And
problem.
good for patients who are staying in their homes and not getting other stuff.
And also they don't even sit at home. A lot of them go out. They've just got their own monitoring on them.
How dare they?
Yeah, I know. It's ridiculous. And then post-working, so we've spoken to Royal Mail about this. It's remarkable. This is what I mean though, and something that consistently came up in the primary care report. There are so many ready-made innovations the NHS could roll out tomorrow that they're just not using. And some of that's because, it is quite fragmented. So primary care is inherently fragmented, so are hospitals, and they're quite difficult to enter into. You have to make complicated business cases. There's so many different obstacles. But I honestly could make a list off the top of my head right now of things that I know you can do tomorrow. And then the trust between professions. So I think, like you say, there are some interesting cultural layers to this that I can't get into because I'm not a doctor. Obviously, I do speak to doctors about this. But so much of it comes down to communication infrastructure and just making that a bit more straightforward. Like as Claire was saying, it's actually not that easy for GPs to just walk into hospital and talk to their colleagues. We hear it consistently that it's needlessly difficult for different doctors in different sites to get hold of each other. And if you could actually just create the communication channels, which is fairly straightforward and has been done for literally decades in any other industry in the world, is extremely complicated in the NHS. And if you were able to build up those communication channels, I think a lot of distrust could disintegrate fairly quickly.
Thank you so much. Lots of good stuff there. And it's almost like you chose the questions deliberately for the stuff that we're looking at. So thank you. Lord Warner, you wanted to ask a question. And then there's a hand at the back and a lady there with the glasses on the head. And then there's a lady in front as well. So we'll take those 3 for now, please.
My question relates to what Dominic Cummings calls the blob. And you have to look at the blob if you want to get some of these funding issues right.
Who are we defining as the
The
blob?
blob is the Department of Health and
NHS England.
Both of them.
Yep, okay.
Both of them.
Yep.
And I say that as someone who has been in the tent looking out. And in 2006, Patricia Hewitt and I produced a rather good white paper
It's a very good
of how you get more of this work done outside acute hospital. Guess who stopped the proposal to force that down in terms of change by controlling the flow of the money from the Department of Health? It was the Permanent Secretary.
Yeah.
Guess who, when we moved to 2017, and everyone's crying out for a workforce plan, and there was a House of Lords rather good report in 2017 about the long-term sustainability of the NHS, and saying that the key, supported by Simon Stevens, the key was a workforce plan. And guess who came along and gave evidence and said it wasn't his job to actually do a workforce plan? The Permanent Secretary of the Department of Health, now the Cabinet Secretary. So the blob is quite important. Unless you tackle the blob, and John Hutton and I gave evidence to a House of Lords carefully saying you need to control the flow of money out of the department.
Absolutely.
My question to you Charlotte, and to Rosie, when is reform going to see the Treasury as the saviour to tackle the blob in the NHS?
Wow, that is a great question. Okay, we're going to come. I've never heard anyone say Treasury is the saviour, so I love that. That is a brilliant turning on its head of the popular wisdom. Thank you. I would expect nothing less. Exactly. We will definitely come back to that. Thank you. And then, so the lady with the glasses on your head, and then there's a lady in front.
So I think what we're hearing very clearly is that secondary care is very unhappy, primary care is very unhappy, and patients for the most part are terribly unhappy as well. I'm just wondering, where does reform stand on co-designing services with patients, for patients, than lots of people sitting making decisions on services without, because I'm doing lots and lots of work, sorry, I'm in patient experience obviously, It's
With who,
amazing
sorry,
work.
where are you from?
Georgie's, St George's in Epsom and St Helier.
Great, thank you. Okay, perfect, that's a good question. And then, yep.
I'm Sana Forster. I work at the Health Foundation. I'm also an academic historian of the NHS, so it's nice to see some primary source
Brilliant.
material.
But I also
wondering, I just wanted to push people on ICSs.
Yep.
Like them or loathe them, they're not probably going anywhere. What role should they play in this landscape?
Great. Thanks, there's 3 brilliant questions. Let's end on the blob and the Treasury, and let's take the other 2 first. So, co-designing services, I mean, Claire, you talked about this at the start, you said it should all be built around the patient. So.
And let's not, again, reinvent the wheel. Okay, so there are, there's a report in 2014, commissioning for London, which actually communicated with nearly 1 million Londoners to find out what they wanted and to start to co-design, which is where those standards came from. We've got the NHS Assembly at 75, which I co-chair, which did a whole bucket load of work with patients and carers and users around what the NHS should look like. We've got the current process that's going on, the NHS planners. And we've also got a whole load of initiatives that have been created over the last 30 years to co-design at local level. So I agree with you, but I would turn it round now and say, what compact should patients have with the NHS? I mean, I'm particular, we talk about data. At the moment, we have a ridiculous system where we don't share data across primary and secondary care. We don't use data we've got the biggest wealth of data in the world, the UK PLC, and it's been blocked. I hate to say that some of the people in this room might be, I won't say who, the organisations they work with might have been instrumental. So I think it's about working together with patients. And I think we infantilise patients to unbelievable extremes. We say they can't use a smartphone. Oh, of course they can. My 85-year-old mother, before she died, learned how to use, there are some that can't. So I think you're absolutely right. I think we should start to say the patient in this and how can we empower them and how can we get them to help us with the technology changes that are needed.
Brilliant. Which one to pick up next? So, Nicola, did you want to pick up ICSs? Oh, is that a bit of a hospital? Pardon the pun?
Do you know what, honestly, you may have seen that the college put out a bit of a storm a couple of weeks ago by showing unedited the experiences of 5,000 nurses over a 2-week period of what it's like to look after people in corridors. Absolutely shocking reading, heartbreaking reading actually from a patient and from a professional point of view. The whole point of an ICS is to be able to properly look at local services for local people. I would argue, since they have, on basic things like patient flow, basic numbers in and out of hospital, to actually commission for local care. They've been in place 2 years, and I think it's been the worst corridor care on record this winter. And I find it so disappointing that the primary discussion that I hear coming from ICS is the financial bottom line, whether they're in a positive or deficit. That crippling focus on money is stopping any kind of local innovation to properly sort out care. So I think what they have been put into and what is the actual outcome at the moment, I would say, is very, very limited. And I'm going to probably say something a little bit controversial that may go against a lot of what people say, but we are in crisis. As was said, if patients are unhappy, the people that work in hospitals, community, what do you do when you're in crisis? You are very, very clear who is leading. I could not see at the college who was leading this winter. Was it the department? Was it NHS England? Was it the ICSs? When you're in a crisis, which we are, who is actually leading? I cannot see that. And if you learn anything in a crisis, you need 1 or 2 key leaders that you need to follow. Our current system is a peacetime model, and we are not in peacetime. And I'm really worried unless something shifts.
Thank you. And Rosie,
And the blob.
Rosie the blob, which I guess kind of also links to the ICS kind of question. But I mean, we have called for the abolition of NHS England, and you're right that there are fundamental issues within the department as well. So, do you want to take on that one and whether the Treasury needs to ride in and rescue?
Yes, I mean, so I would agree on the problem analysis that maybe the civil service could be part of the problem. I probably disagree on the solution that the Treasury is the answer. I think that, like as Charlie alluded to, and to answer the ICS question at the same time, if you really wanted to, if you think about the future of the ICSs, you would just scrap all the targets. We had scrap all the targets coming from NHS England. With the operational guidance, the NHS last week, most of it again, with a lot of the primary care targets were removed and replaced with hospital targets. Once ICSs are given these targets from central government, they literally have no space but to do anything else, and often end up in deficit anyway. That's assuming, like I say, assuming they're not running into deficit anyway. I think the future is, if you wanted the future of ICSs, is kind of just relinquishing the central control. And like I said, I don't think the answer is in the Treasury. I think that actually there are divergent needs across the country, and they are actually better solved by local decision making. Ideally, we think that should be a different institution to the ICS, and also not necessarily NHS England. But like I think there is a shifting role for the centre. I don't necessarily think that the shifting role in the centre is in the Treasury, though.
I have no faith in that local at this moment in time. That's my worry. We know that the state we're in is what it was like when, before New Labour came in last time. And actually, whether we like it or not, things did. So, patient experience, 70% satisfaction, diagnostic pathway meant something, A&E target meant something,
choice meant something.
Everything meant something. And what that was not local, it was a massive command and control, whether we liked it or not.
The problem with that is that the investment levels of New Labour were 3 times GDP
Which is even
so
more
we
reason why
don't
you need to
have
mandate.
the option.
But even more reason why you need to mandate.
100%.
You can't just, we're wasting so much time and money, duplication of roles on ICS. It is, so it's even more, if we're in a crisis, which we are, to not, money is, of course we're not going to get
Well, I mean, you'd only have to look at how many people are sitting in NHS England and DHSC now, like
But I don't like
14,000, 16,000 people sitting in central government, like, you want to be spending that money on the people who are delivering the services and investing in those areas, whether it's digital, etc. There's a huge bloating of the centre that has to be dealt with.
I think we can't blame.
That's not an individual level.
No, but
at
it's
all.
still
it's a structural
vast
problem.
machinery that is being run, and I think we need people to run that machinery. The problem is they're running the machinery in the wrong way, because I think if I was to say to NHS England that they need to be much braver.
They do, yeah.
And not, so it's not necessarily about Norman getting rid of NHS England, it's about being braver about the resource and actually accepting that if we want to get more for our money, we have to focus on prevention, and the only place to stop that old lady going into A&E and lying on a gurney for 12, 18, 24 hours, if I can do a home visit, or if we can get a nurse. We haven't got any nurses, so...
Which is exactly why the decisions have to be made in a local area, because no one sitting down the road here in Waterloo can do that.
There's one GP and maybe one nurse, so there's nobody at local level to make those improvements.
No, we need to invest in that, precisely, rather than in the centre. We are almost at time. We probably have time for, I think, just final. I'm really sorry, there's so many questions. We have got tea, coffee, biscuits afterwards. Please stay around and talk to us. Don't eat a biscuit. And do eat a biscuit if you like. I'm sure you can all be responsible individuals that go for a walk as well or something to deal with that. But I did want to just come back. I'm so grateful. This has been huge fun to chair, genuinely. I do love a bit of controversy or a bit of challenge, so thank you so much, you have been fantastic. I'm just going to come for a final thought. What is the most important thing, if we could do one thing to really ensure that we get this shift to prevention? One thing.
Fund digital and data.
Fund digital and data. Rosie?
Change the funding incentives in the health system.
Lovely.
Investing nursing in community.
Brilliant. God, that was so succinct. Thank you so much, everyone, for joining us, and thank you.